Great. Thank you all for coming today. We'll probably wait another minute or so. I think there's still a few people coming in, but we'll make a start then. It's a great pleasure to welcome Shouvik Haldar to the group. So I've known Shouvik for a number of years. He's a force of nature, really, for trying to improve education, and we're really grateful for his work, really across cardiology to, bring patients and clinicians and their education really to the forefront. Shouvik's a very experienced electrophysiologist, working mostly out of the Harefield Hospital in London, but as I said, has really been pivotal to kind of educating all of our trainees across the country and across the world, in fact, as to how to manage AF rhythm control. So we're really grateful for him to come and share his experience with us today about when we should be reassuring patients and when actually they could do with referral into the sort of services that he and his colleagues around the country manage. So thank you, Shouvik. We're really interested to hear what you say. If anyone does have questions and stuff, we'll try and get through as many as we can. As you know from these meetings, there's often usually many more questions than we've got time for, but hopefully Shouvik will be happy to answer them afterwards as well, via email and stuff. But if you've got them, then use the chat or the Q&A, and the DaRe2THINK team will pick them up. Once Shouvik's finished, Minnie will just give you a quick overview if you've been involved in DaRe2THINK or are interested or need some more support as to how you can get that from the team. Great, thanks. I'll hand over to you, Shouvik, and really eager to hear what you've got to tell us. Thanks.
Thank you so much for that nice introduction. I'm going to share my screen in a second. Here we go. Hopefully you can see that now.
We can, thanks.
Lovely, thank you very much. So thanks, Deepak, and thank you to the DaRe2THINK team for the invitation. And yes, indeed, we're gonna talk today about AF rhythm control, and when to consider referral and when you can reassure. And I think it's important to say that this is probably complementary angle to the work that you guys are doing in DaRe2THINK, where you're thinking about how to optimize rate control for many of our older patients with atrial fibrillation. But rhythm control has really come to its own in the last sort of 5 to 10 years. So we're going to spend a few minutes talking about that. These are my disclosures. So I'm going to start right from the start by saying that I think the paradigm has completely shifted in the last 5 to 10 years. I think we used to think with our AF patients that, you treat them with rate control unless there was a reason to intervene and think about rhythm control. Whereas I think more recently things have changed, and that's because there's overwhelming evidence now to support a much more earlier rhythm control strategy. So definitely I think things have changed so that the thinking now is rhythm control whenever actually feasible. And my stance today very much is thinking about rhythm control very early and aggressively, but of course appropriate triaging of patients still matters. And I'm going to touch very briefly upon why that stance has changed by showing those three panels that I'm showing you now. So the first left panel is a really important study called EAST-AFNET-4, published in 2020. A fairly simple study in that they compared usual care versus early rhythm control, either with the use of antiarrhythmic drugs or catheter ablation for patients with AF. And they took all comers, including first-time AF presentations to those with paroxysmal and persistent. And this, I have to add, is one of the first studies where they really use hard endpoints to look at what happens with potential intervention in AF. And they found a very clear reduction in some hard endpoints as a primary composite of cardiovascular death, stroke, and heart failure hospitalizations, a 20% relative risk reduction in the early rhythm control group. So that's one study that was really important. The next study, this is just one example of many studies conducted of this nature. This is essentially comparing in paroxysmal atrial fibrillation, first-line ablation versus antiarrhythmic drugs. And you can see the Kaplan-Meier curves clearly diverge in favor of ablation at 1 year. So a significantly higher proportion of patients do better in terms of freedom from AF at 1 year if you ablate upfront as a first-line management strategy. And there are a number of studies. I'm showing you one example of a Kaplan-Meier curve. There's been several studies of this nature showing the same results. The final panel is quite an interesting panel in that it shows a Kaplan-Meier curve where they looked at what happens to the progression from paroxysmal to persistent AF if you compare strategies of catheter ablation versus antiarrhythmic drugs. And they showed out to several years that if you acted early, you massively decreased the progression of the substrate from paroxysmal to persistent AF. So that's why the thinking has changed. With those sort of studies that have been published in the last 5 to 10 years, our strategy for rhythm control is much more aggressive. So let me start with a quick case. These are all real cases of mine, fairly recently, some of them. This is of a 52-year-old lady, fit runner, body mass index normal, blood pressure normal, doesn't drink much alcohol, no past medical history, essentially a clean bill of health from what you see from a history. Mother had a pacemaker. The patient's, as I said, a fit runner, but is getting palpitations and they've got a watch, as everyone does nowadays. And the Apple Watch gave a reading of possible atrial fibrillation. And this is the actual strip that I'm showing you there. So if you look at it carefully, you can see firstly that it's labeled it as atrial fibrillation at the top there. And if you look at the strip itself, it's a little bit difficult to discern. There's clearly lots of artifact here. But maybe there's a P wave here or there, but I guess it's sometimes hard to call. And certainly the watch has made a potential call here, but whether it's right or wrong, we don't know. But having said that, the patient is worried about that this has been shown and is worried about their stroke risk and their need for blood thinners. The question is, can you just reassure this patient or do you have to think about referring? Well, you can probably reassure this patient if you're adept at analysing these single lead ECGs. But in this case, the patient was referred to cardiology, probably quite rightly, to have a more prolonged period of monitoring. In this case, they had a 7-day Holter, which came back and showed normal sinus rhythm. And they had an echo test done as well, which showed normal, structurally normal heart. So on that basis, no anticoagulation was recommended. But I wanted to just take an opportunity to show you that strip again, and then show you a further strip from that patient, which is actually from the same day. And this is labeled by the watch sinus rhythm. So you can see if you look at this strip, it's much more clearer to discern that this is sinus rhythm. The QRSs look regular. You can see P waves in front of the QRS here. And if you compare this with this strip, some of those features can be seen here. So there, you can see that this is probably sinus rhythm from those beats, but other beats, it's hard to see the P wave. And of course, the artifact messes things up overall, and that's why the watch was probably misled. But the clue here is that if you compare normal strips to the ones that are labeled as atrial fibrillation, you can see if it's actually underlying sinus or not. The other giveaway is that the rate is within normal range, which is usually unusual for if you have episodes of atrial fibrillation. So it's worth pointing out that we are seeing more and more of these wearable devices in terms of ECGs. I'm sure you are seeing them in primary care a lot. If you've got a low-risk population, it's worth pointing out that the sensitivity can be high, but the actual specificity falls quite low, particularly in this sort of population where you've got a young, fit person. So do you reassure or do you refer? Well, it depends on how adept you are at analysing these single-lead ECG strips. If you're unsure, I'd refer because you want to get a clean, you want to commit properly to whether this is an arrhythmia or not, because on that basis, you might be referring for anticoagulation or further management. So I think a reassurance only once you've done further investigation, and that's usually via the channels of referring to cardiology. On this case itself, let me show you another example. This is of a 75-year-old male, but this time with multiple cardiovascular risk factors, no real symptoms, and actually had an opportunistic screen with a cardio mobile whilst they're at their local pharmacy. So this was a strip taken by a pharmacist doing an opportunistic health screen using the cardio mobile. And this is the strip from that very patient. And you can see here, if you look, it's very difficult to understand what's going on here. It's a poor tracing. It looks irregular. I don't think you can discernibly tell if there are P waves. So it's really hard to call. And on the basis of this strip, the patient ended up having, at their GP practice, a 12-lead ECG. And look at that ECG on the right. Very clear that this is atrial fibrillation. It's unambiguous, ventricular rate of 110. So when you come across these single-lead ECGs, whether it's from a cardiomobile, an Apple Watch, a Fitbit, I think you've got to understand that there are limitations. It could be sinus, it could be atrial fibrillation, it could be something else. But if you're not sure, you need to confirm with a 12-lead or a Holter or whatever before you commit to further management. So it's just to give you a warning about these ECGs, to say that, you know, unless you've got lots of practice analysing them, they can be quite tricky to discern. So I'm going to move on, because we've only got a few more minutes. Let me talk to you about this next case. 53-year-old male, company director, leads a relatively sedentary lifestyle, drinks too much alcohol, is an ex-smoker, has hypertension, his body mass index is elevated, and has come with a recent, fairly sudden history of paroxysmal palpitations. He describes them as fast, lasting for 20 to 30 minutes at a time, and associated on occasion with chest tightness. He's highly, highly symptomatic and bothered by these, and it is limiting his ability to work. And this is the ECG done at the GP practice. So if we take a moment to look at this ECG, and when you first look at it, you think, oh, it's not too bad. Looks like sinus rhythm. But then you're seeing, you know, what looks like an atrial ectopic here, because the QRS morphology is similar to the sinus morphology. And then you look later on the strip and you see a few clusters of these. So it looks as though this patient is sinus rhythm, not atrial fibrillation, but having frequent atrial ectopics. So in itself, you might think, well, it's probably okay. And, you know, you could quite easily fall into a trap and think, well, he's relatively young, probably not as fit as he could be, drinks too much. Perhaps let's look at lifestyle, reassure and review in 6 months. But actually, this patient was referred, and I think quite rightly, and went on to have a bunch of further investigations, as we tend to do in hospital medicine. So let me show you the things he'd had done. An echocardiogram, of course, pretty much a normal heart, apart from a slightly left atrial chamber that was big. As he went on to have a CT coronary angiogram because of the chest pain and the prior smoking history, and that showed just diffuse non-obstructive atheroma, so nothing that needed any intervention. And then the Holter monitor, which I'm showing strips of on the side here, which showed, very interestingly, very high burden of these runs of essentially atrial ectopics, which basically is atrial tachycardia, just runs of these long episodes of atrial tachycardia. Now, later on in the strip, I've shown you these, but there were several of these throughout that monitor, and some of them degenerated into atrial fibrillation at the end of the run of atrial ectopy. So putting this all together, you've got someone who clearly has cardiovascular risk based on lifestyle, based on the fact that there is atheroma in the coronaries, and the fact that he's gone into this rhythm disturbance in the last few months. So what do we do for him? We treated him with standard medical therapy, so statin, bisoprolol, and DOAC, because if you look at his CHAS-VASc, with the fact that he has, if I go back and show you, he is hypertensive, and he obviously has coronary atheroma, vascular disease, so that gives you 2. So on that basis, we started anticoagulation. Also, because we were thinking that this chap probably is going to end up having an AF ablation. So that's what we did in terms of management plan, started him on medication, advised him in regards to lifestyle, in particular to reduce and stop alcohol in his case, and of course to try and lose some weight, incorporating a regular sort of exercise program. We also listed him for AF ablation. Now, we do that now because obviously the waiting list, I'm sure locally in Birmingham, is going to be the same. Your wait lists are going to be 9 to 12 to up to 18 months. So if you're thinking someone is going to need an intervention, get them on the AF ablation waiting list quickly, treat them in the meantime, and then see where you end up. And if you are thinking that they may improve, then it's worth having a stop point somewhere in the middle to recheck them. And that's what we did. But before I show you that, I wanted to show you this panel on the left. It's a very powerful study done in 2016 from colleagues in Adelaide. And essentially, the left panel is showing you what happens with sustained weight loss of over 10% if you do nothing apart from lifestyle modification, as in no antiarrhythmic drugs, no ablation, compared to those who do much less in terms of weight loss. You can see that this is freedom from atrial fibrillation out to about 5 years, a huge improvement in AF freedom when you lose 10% or more weight. If you add an intervention to that picture, say AF ablation, as in this right panel, less so on other weight loss strategies. So in this case, I'll tell you what happened to the patient. We did a follow-up at about 4 months' time. Because of his highly symptomatic palpitations, I wanted to see what happens with increasing doses of bisoprolol. We got up to 7.5 milligrams. He took the lifestyle advice really seriously and stopped alcohol, started walking, and improved his just work-life balance and sleep, etc. And this was his Holter monitor. Basically, you can see that his heart rate was 55. That's a reflection of the bisoprolol being at 7.5. But he had sinus rhythm throughout. All of the runs of atrial tachycardia, atrial fibrillation we saw, which was very pronounced in that initial Holter, it essentially disappeared. And that's with him doing all the lifestyle stuff, achieving 4 kilogram weight loss, and actually, I have not yet ablated this chap. He's managed to do it all by himself with just lifestyle. Now, this is just a powerful case to reinforce that risk factor modification is so important. So whenever you see your AF patients, alongside your beta blockers, your anticoagulation, do give them that pep talk. It's hard to keep following them up to see if they're following it. But if you push that message home really hard, and if they take it to heart, then they can make a big difference to their AF, and you can even stop interventions like in this case. Final case, 61-year-old female, comes with a very clear history of fairly recent 6-month history of breathlessness on exertion, denies chest pain, blood pressure's up, BMI is up, known blood pressure history, and is on ramipril. And you do an ECG in your surgery, and the ECG shows atrial fibrillation with a fairly controlled ventricular rate. So what are you thinking here? Well, in essence, the story is very clear in terms of change in history. And when you've got a static 12-lead ECG showing atrial fibrillation, I'm thinking to myself, well, there's been a clear change 6 months ago. Although I can't say just from a single ECG, I suspect that this is a persistent AF scenario because they've felt rotten for the last 6 months. You would be thinking today, I want to anticoagulate them. Their CHAS-VASc, or rather CHAS-VA score is 1. Remember, we're not counting female sex in the CHAS-VA score as of the most recent AF guidelines from 2024. So this patient scores 1 from hypertension, but nothing else. So 1 is enough for initiating anticoagulation, although there is that thing where you have a discussion with your patients about whether you want to start anticoagulation or not. But for this patient, you're probably going to think, well, this is atrial fibrillation. I'm probably going to refer because I would like them to consider rhythm control. And so if you're thinking along those lines, then I would best recommend that they start anticoagulation because we do need it, whether we do a cardioversion or consider them for AF ablation. So for this patient, I think you can act today by starting appropriate medical therapy. Of course, give them the pep talk about risk factor modification, in this case, BMI, and hypertensive control is the key focus, and then get them referred to have a conversation about rhythm control with their secondary care cardiologists. So why early? East AFNet study I talked about briefly before. The reason why we talk about early is because that study showed that if you act within the first 12 months from diagnosis, you're likely to get a better result. And we see that in our clinical practice. if we intervene early on in the patient's AF journey, we get much better freedom from AF results in the longer term. And of course, I've shown you those studies where paroxysmal atrial fibrillation is best treated versus antiarrhythmic drugs first line. But if you add those two converging lines of evidence, if you've got someone in persistent AF and you've caught them early, let's say within the first 12 months, you should try and ablate them as soon as you possibly can. I haven't included the slide where I talk about the current NHS guidelines, but current guidelines for us recommend that if you have persistent AF, you should ablate them within 12 months ideally, but they don't formally allow you to ablate them after 2 years of continuous AF, because then after that sort of time, you start to get diminishing returns from success. So for your newly diagnosed persistence, I would think about anticoagulate them if they're CHA2DS1 or more, optimize their modifiable risk factors, and refer for rhythm control, because we know they do best if they get that rhythm control within 12 months. And we all know the patient journey is going to be long, from referral from primary care to seeing us and then being put on the waiting list. So act early to have rhythm control. And I wouldn't accept rate control as the destination. Rate control is important, absolutely. You want to start it as background therapy because you want to reduce impairment of their left ventricular function if left uncontrolled. But you should add it as an adjunct to potential rhythm control conversations. I sometimes talk it's worth talking about here. The patients you can absolutely reassure are the well patients who may have an incorrect wearable alert, but you can see it's sinus rhythm. You may or may not wish to confirm with monitoring, but if you've got someone who's well and you're fairly confident it's sinus rhythm, then of course you reassure. If you've got someone with frequent atrial ectopics, short runs of SVT, but no sustained AF, you could potentially reassure, but I would be tempted to think about referring because you want to see if there's something more going on or not. And of course, if you've just got the palpitations patient, but with no formal diagnosis, but the ECG and Holter's normal, then you can potentially reassure. But I would be treating and referring most patients where you have a suspicion of atrial fibrillation. I'd be anticoagulating them as per the CHA2DS score. I'd be risk factor modification very early on, and I'd be doing the rate control in the background. And of course, slam dunk in terms of referral for us is the symptomatic paroxysmal atrial fibrillation. We want to be ablating them pretty much as soon as we know about the AF. Persistence as soon as you can, because the longer they're in persistent, the worse it is in terms of outcomes, in terms of when we actually get to them. And any patient that's had a procedure, such as an ablation, and if they have a new arrhythmia, we would tend to want to see them because they may have things like ablation-related atrial tachycardia, which may mimic sinus tachycardia, but actually may be something that we need to get on and treat. And remember, the same patient can often live in various of these boxes, so you've got to use a bit of clinical judgment to figure out who you can treat, reassure, or just refer on. Now, I wanted to just briefly mention that, of course, when you're taking history, remember the red flags. So anyone with pre-existing structural heart disease, heart failure, valve disease, etc., or anyone with exertional symptoms, syncope, pre-syncope, or any family history of sudden cardiac death, we would want to have referred to us. And that, what I'd say, is a fairly blanket red flag sort of indication. So I think my time's up. It's very short. I've whizzed through them. And I'll stop there and ask for any questions.
Fantastic. Thanks, Shouvik, for that masterclass. I'm sure it'll be really helpful for everyone. We've got time for a couple of short questions. There's one here. Just to clarify, this is from Abidemi in Towcester. Just to clarify, are you saying all patients with newly diagnosed AF need referral to cardiology?
Yes. Pretty much I am, actually. And I mean, unless someone's 90 years old and there's no chance for, intervention. The reason I say that is because there have been so many patients that we have seen at a tertiary centre level that have been managed either at primary care, combination of primary and secondary care, perhaps have had multiple cardioversions or X, Y, and Z over several years. But when they come to us, it's actually a bit too late. We've missed the window of opportunity. And if you factor in the timeline for assessment, referral, seen in clinic, then referred and put on a waiting list, that in itself is probably longer than the optimal time the patient should wait for an intervention. So I would rather see the patient and make a decision early on in their disease course, whether it's for intervention or not, and make that call early, rather than then come to us too late and we say, you know what, you've missed the boat probably. And the NHS are getting quite strict on this. As I briefly alluded to, they would want us to ablate paroxysmal patients early on, and persistence, they do have a bit of a red line if you're longer than 24 months in duration. There are other exclusion criteria, but those are the key ones. So yes, I would want to see these patients for consideration early.
Right. And then a question on catheter ablation. Are there any side effects or serious adverse effects of catheter ablation versus medication options? And what effect would increased numbers of referrals for ablation have on cardiology waiting times? Is very pertinent.
Yeah, absolutely. I mean, this as an...
Sorry, Shouvik, we just lost you. If you can, I think,
we need people
can
living
you start that again? Because we just lost your connection. Yeah.
Oh, sorry. Yeah, I appreciate, yes, our workload is going to get much higher. I get that. But actually, if we can do something early on for these patients, we'd rather do so. The first part was about side effects or what are the adverse events. Actually, in the last couple of years, we're using newer technologies with newer energy sources. They are super safe. We used to do 2 ablations in a day. We're now doing up to 4 or 5 in a day, sending many of these patients home the same day. I think ablation has got much safer, quicker. So I would be not hesitant to refer most patients for an ablation.
Great. Thank you so much. There are more questions. We'll try, and if there are any more you want to put them in, then we'll forward them on to Shouvik, and then we'll try and get a response. I think there was one question about anticoagulation, but remember that AF is just the tip of the iceberg. Often there's an underlying atrial cardiomyopathy, so we don't recommend in the guidelines to stop anticoagulation, because often there's a underpinning risk for these patients to get long-term stroke. And of course, our main aim is to kind of protect these patients for their lives. So, but if there's any other questions, that would be great. I'll just hand over very quickly to Minnie just to get an update for you guys who are listening. But thank you so much, Shouvik, and we really appreciate your time and expertise and sharing all your insights with all the primary care teams that we have across England. So thank you very much.
Thank you.
Minnie, if you want to take over, that'd be great.
Yeah. So thank you very much. So the DaRe2THINK trial is a randomized controlled trial to prevent strokes, premature death, and cognitive decline on patients with AF using their healthcare data for pragmatic research. So the trial is being run across primary care in England, and we are addressing a major public health concern, which is to prevent dementia. So we are doing a weekly screening of 13.5 million patient records, and at present there are more than 500 practices who are actively engaged in the trial, and we have randomized more than 1,300 patients. So for each practice, the average is that for every patient, 5 patients are recruited, 1 patient is randomized. So Abby, next slide. So the trial is easy to set up, and we have a new improved trial platform that will enable you to quickly recruit and randomize patients. So for those practices who have not yet joined the trial, can you just click the right QR code to book an introduction meeting so we can explain the trial with you. And for those practices who are already on the DaRe2THINK trial, and if you have any query, you can click the left QR code so you can book an investigator meeting with us. Thank you. So the next webinar would be on the 8th of July, the same time, 1 to 1:30.
Great. Thank you all very much.
Thank you.
Great to see you. Have a good day. See you soon.